So I'm going to start with just a small introduction. Would like to welcome everybody with us tonight. Again, it's Friday. We'll try going to do this surgical grand rounds in terms of challenging cases, hopefully every week. Especially we have a complete curfew and a lockdown in Amman, Jordan, every Friday. Yes, last week it was a colorectal liver metastasis, and it was a huge success of more than 300 participants on Zoom and more than 1,000 views on Facebook. Today, our theme is pancreas, and I would like to welcome my panelists. We'll start with Dr. Ahmed. Dr. Ahmed, he's a mentor, a friend. He's one of the greatest and smartest surgeons that I have worked with. He's behind all the success that I had in my life through pushing me very hard to excel and succeed in my career. He's a principal investigator in multiple randomized trials regarding the science of management of pancreatic adenocarcinoma, as well as other malignancies, including high-PIC and benign pancreatic pathologies. He's the director of the surgical oncology and at the Cancer Center in Cincinnati, Ohio. And my colleague, who I also worked with Dr. Ahmed and trained in Cincinnati, Dr. Mohammed Zahrani, he is a surgical oncologist, and he's the executive director of the National Guard Health Affairs in the West area in Saudi Arabia. He's trained at Harvard for head and neck and endocrine malignancies, as well as lung Kettering hepatobiliary. Our female colleague, Dr. Rola Ammarin, she is a consultant medical oncologist at King Hussein Cancer Center. And Dr. Basil Amouri, he is an ex-HCC, KHCC, he's now in Burjeel. He's a pioneer in laparoscopic management of pancreatic malignancies. And Dr. Ihab Shhade, he's one of the most experienced gastroenterologists in Jordan with EUS and pancreatic head tumors and malignancies. And finally, Dr. Ali Dabbous, he's going to be also a speaker. He's a consultant transplant and oncosurgery at King Hussein Cancer Center. So for the sake of time, again, we make these cases are interactive as possible. I would ask Ali to start sharing his screen and start presenting his case. Fadal, Ali.
Okay. You can see the screen now?
Yes.
Okay, so first of all, thank you all to join us, and thank you, Osama, for arranging such informative teaching surgical round, which I think this is the way we can teach our residents and fellows, by doing those discussions about the cases and thought storming. So our case today will be about pancreatic surgery. So our patient, she's a 52-year-old lady, past medical history, diabetic, surgical history, lab sleeve gastrectomy, lab chole. Family history was free. She just complained from abdominal pain for almost 2 months and intentional weight loss. And she was walked up outside our institution. And by doing an image for her, found to have a mass at the ansenate process. Her labs was unremarkable, apart from CA19-9 was 450. This is the CT scan done for her. This is the, sorry. So the finding we have at the CT scan is an ansenate process about 3 by 2.5 centimeter lesion. This lesion was abutting one of the tributaries of the SMV, which is the ileal tributary at that area here. There was no huge dilatation in pancreatic duct. The biliary system was not dilated. The patient was not jaundiced. The liver was free. There is no evidence of peritoneal metastasis or ascites. Also, the lung was free. Let's move. So for our joining fellows and residents, here is the ansenate process mass, and this is the ansenate process, and here is the two tributaries of the of the SMV. As you know, we're going to show you now picture from the anatomy that the SMV is forming from the joining of the ileal and main ileal and main jejunal branch, and then we're going to have the first jejunal and all these things. So the tumor is just abutting this area. This is the arterial phase, and it's very important when you deal with pancreatic cancer to have a well done arterial and venous phase CT scan, because this will help you to assess the resectability and the involvement of the vascular structure. So the arterial phase 1 was negative. There was no involvement or abutment to the celiac, hepatic, or superior mesenteric artery. So this is the superior mesenteric. As you can see here, there was a nice plane in between the mass, and there was no even suspicion of involvement or even abutment to the artery. This is the coronal view, and as the radiologists like to call it, the surgeon view. I just put it here to make it more easier for you guys. Here you can see the mass, and the tumor is abutting this area, which is again the ileal. And here just I painted this for you. This is the uncinate process here. This is the portal, the splenic. So here the area where we suspected a little bit of narrowing, and here the area where we have the attachment or the abutment of the tumor to the ileal tributary. So this is just to clarify for our resident. As I said, this is the SMV. It's mainly formed by the junction between the jejunal and ileal tributary. Our problem was, we expected our problem here. So I'm gonna start my question to Dr. Sayed. How do you think the image is accurate in delineating this? Yeah. In another way, how many times you have like underestimation or superestimation to the involvement of the vessels by the image only?
So can everyone hear me?
Yes.
Yeah. So I think different institutions have different modalities of evaluating patients. Some predominantly use high resolution triphasic CT scans with thin cuts through the pancreas, usually 1.5 to 3 millimeter slices. Other institutions use MRIs. Our preference here is a combination of CT scan and then endoscopic ultrasound to evaluate the tumor vessel interface. And I think, to answer your question, how accurate, I think local staging is very accurate. I think there's still about a 10 to 15% incidence of occult metastatic disease that our current modalities may not pick up. And so I think that the ability to appreciate the tumor vessel interface with high resolution CT scan or MRI is very accurate. The quality of the CT you showed me is pretty good. I'd be comfortable with it. There's always especially with uncinate lesions, there's always a chance that there is tumor spread in the meso pancreas, the amount of tissue that attaches the uncinate to the SMA. It's very similar, when I teach my residents to think of it kind of like the mesorectum when you do rectal surgeries, that there can be tumor spread in the tissue attaching the rectum to Waldeyr's fascia. Similarly, there can be tumor in the tissue connecting the uncinate to the SMA, even though we don't see that on CT scan. So I think that you can't image that any better than what you have. So I think either a high quality MRI or CT in combination with endoscopic ultrasound for local regional staging is very good. It's still about a 10 to 50% chance of missing occult metastatic disease with our current modalities.
So Dr. Ahmed, another question. Do you as a surgeon attend the EUS or at least look at live images of the EUS? or just you rely on the report? And I would like also Ihab to comment on this after Dr. Ahmed.
Yeah, so I don't have the expertise to look at endoscopic ultrasound. I mean, I can look at it, and I rely very heavily on my gastroenterologist. We review all our patients in a multidisciplinary conference, and we review all our imaging together. Sam, you've been in our multidisciplinary conference. Every patient gets reviewed weekly together. We have a pathologist in the room to look at slides. We have a gastroenterologist, medical oncologist, radiation oncologist, and surgeons, and we go through every patient together. And we rely on the gastroenterologist colleagues to really interpret the endoscopic ultrasound for us.
Ihab, how accurate is the EUS to accurately predict venous and arterial involvement based on your experience?
Well, experience and literature as well. The CT is better evaluating the arteries. We are better evaluating the veins. So we can look at the portal vein, superior mesenteric vein, really better than the CT scan can. And we sometimes can look into whether this is abutting versus actually loss of interface, which is the earliest sign of invasion. And it's always a doubtful for us. But when we have complete loss of interface between the tumor and the vein, that's usually very early invasion. Of course, obvious invasion is usually seen on both the CT scan and the EUS, but it's that intermediate phase where is it invading or abutting? I think EUS is actually better than the CT for the veins.
Okay.
For the arteries, some of them are actually further away from the probe, and for EUS, if you've experienced EUS, the closer you get to the probe, the more accurate we are.
Okay.
The further you go away, the less accurate we become.
Okay.
And for peritoneal mets, I have picked up multiple cases, let's say, of very early peritoneal metastases and teeny tiny amounts of suspicious ascites, which were not seen on the CT scan as well.
Okay. Thank you. Go ahead, Ali. Proceed.
So just one to add, I agree with Dr. Sayed. We have 5 to 10% of tiny metastases that will not be able to find even with perfectly done image with an MRI. And we have now more expert radiologists that just dedicated for hepatobiliary cases. But again, my question about the vascular involvement, especially for the situation like uncinate process, any tumor will be very close to the vasculature, as we know. And to say that this is abutting or invading, even during surgery, you cannot even to determine whether this is invaded by the tumor or just very close to it. So sometimes, because the vein is very delicate there, you're going to decide to resect and to do control resection rather than to go through a vein and then you got bleeding and then you need to do repair or whatever. So from my experience, especially after we get the resection and anastomosis, we get the pathology, sometimes it just only the tumor have like desmoplastic reaction around the vein and it's very adherent, although it's not involved. And it's more toward the artery. And the overestimation of the abutment to the artery from the images, at least in my experience, I did my fellowship at Baylor, so that the radiologist will say, okay, listen, there is 180-degree abutment, more or less, whatever, neoadjuvant chemo then. And then once you get to surgery, it just only, you need to go underneath the nerve sheath plexus around the artery, and the dissection will be very easily. So I still believe that sometimes the image will overestimate whatever we have. So, as it's very important what Osama asked, I think we are the one who should learn how to read those with time, with more expert, because with all our respect to our radiologists, and they did for sure a great job, they will look at it from their radiological point of view. But for us, we're going to look at it from the surgical mapping point of view. Whether I can get here, I cannot get here. We're going to talk about this later, about the criteria for resectability and the evolving things. So thank you for your comments. I think it's valuable. So now the question for the all attendees, for the tissue diagnosis, what is the best available option? A, should we go for CT-guided biopsy? B, should we go for EUS biopsy? C, ERCP, brush cytology, whatever. D, open surgical biopsy, or there is no need for tissue diagnosis in such case?
Okay, so I did start the poll for the attendees. We have 113 attendees. Can you please start answering? And I will share, that's going to be for only 15 seconds, and we'll share the results with the panelists soon. So we had so far 50 answers. Would like to have everybody 113 answer if possible. What's the next after having this image, this kind of scenario? Okay. So we had around 80 answers. I'm going to end the poll and share the results. So the majority had picked up, 45% had picked up EUS, 13% CT guided, 10% ERCB, 4% open, and E around 30% said no need for biopsy. So what do you think, Dr. Zahrani, in this kind of scenario? Do you think tissue diagnosis is necessary before we proceed to any next step, or something basically we can proceed without tissue biopsy? You're muted, Muhammad.
Thank you, Osama. Do you hear me now?
Yes.
Thanks for this nice activity, and I really commend Dr. Osama effort to try to get more seminars and encouraging residents to be engaged, and then that's really a nice educational activity, and it's very honoring to be with this group, and including Professor Ahmad, who is one of my top mentors in the US. So I'm happy to see him and join with them today. The biopsy of the pancreatic head mass is not a routine step for patients with head of pancreas lesions thought to be pancreatic cancer. So it is not a standard step. However, now with emerging evidence of the value of neoadjuvant chemotherapy in pancreatic cancer, more patients undergo EUS and FNA core biopsy of the pancreas in order to get a tissue, confirm the diagnosis, and give chemotherapy. So the textbook answer, the FNA for pancreatic head mass is not mandatory. However, with the new emerging evidence of neoadjuvant chemotherapy, I would say that probably all patients should get a confirmed diagnosis before initiating the treatment, establish the diagnosis, and initiate neoadjuvant chemotherapy, especially in this case where we think this is a high-risk patient. The mass is large, that's number one. Number two, the CA19-9 in non-obstructed biliary system is high, which is 400 plus. And there is some evidence that says or suggests that if the CA19-9 is more than 200 in a non-obstructed biliary system / adequately drained biliary system, that might correlate with the outcome of the patient, and the tumor load.
Okay.
So in this patient, I would agree with the majority of the group that EUS biopsy is the way to go.
Dr. Ahmed, regarding the use of EUS, I know you are a big fan of neoadjuvant, and I'm sure all of your patients get EUS and biopsy. But let's say the yield of the EUS biopsy in terms of confirming the diagnosis versus, for example, not having a definitive diagnosis. Can you give us more based on what your current practice?
Yeah, so we attempt to give neoadjuvant therapy to definitely all borderline resectable tumors and in most resectable tumors. The exception is when we can't get a tissue diagnosis. So our algorithm is that we'll try 2 different endoscopic ultrasounds to make a diagnosis. And usually that, we're successful, I would say greater than 90% of the time if we do 2 separate EUSs.
Okay.
But if one is negative, we will do a second one.
Okay, and if the second one is negative?
Then, it's patient specific. So if someone has like this patient, for example, with an elevated CA19-9, imaging that's consistent with cancer, a solid mass, we would discuss the patient and say, this is probably cancer, although most oncologists will not give chemo unless there's a firm diagnosis of cancer. Okay. Fortunately, we don't encounter this problem too often. But when we do, then, if the oncologist is not comfortable with the imaging and the CA19-9, then we would consider doing surgery. Okay. But we would try our hardest to get a tissue diagnosis.
Ali, proceed, please.
Okay. So we did an EUS biopsy, and it was negative, reactive cells, no really definitive diagnosis from it. So now, what do you think about the resectability of this tumor? Do you think this tumor resectable, borderline resectable, or locally advanced?
So we're going to relaunch.
Dr. Basil.
We can also relaunch the poll and ask the residents and the with us to answer. What do you think about this tumor, resectable, borderline resectable, or locally advanced? We have 115 participants. We would love to hear from all of you if possible.
Can I ask a question to Ali before we get the answer? What about the EUS? Did it tell you anything about the resectability of the tumor?
Actually, there was no much detail about this. And to be honest with you, I'm not always looking for this from the EUS, although it's very important. So the EUS was done, and then the FNA tissue was scanty, and it was not informative, and there was nothing mentioned about.
May I comment on this?
Yeah.
I think EUS is extremely important in this case. All borderline resectable pancreatic lesions that involve the veins, you should get a comment from the endoscopist, because this is a major advantage of EUS. In addition to that, I don't want to say I don't use FNA anymore. I use FNB, fine needle biopsies, and I take usually an average of 4 or 5 passes. And for any lesion in the pancreas of more than 1 centimeter in size, the chances of getting a negative result is in the range of 3 to 5%. So 95 to 97%, we will get a positive diagnosis when we use fine needle biopsy on these lesions if they're more than 1 centimeter.
Okay.
But to tell you about the resectability, EUS is a major contributor in this case.
So the result of the poll, the majority, 60%, had said it's a borderline resectable, 25% had said it's resectable, and only 12% had said it's locally advanced. Dr. Ahmed, what do you think, based on the images that Ali had showed, is this resectable, borderline, or locally advanced?
So, the concept of borderline resectable is really, if you look at everyone gets kind of stuck on the tumor vessel interface, but really the concept of borderline is a risk of margin positivity. So when this came up, it was kind of touted by initially through a small series in Europe, and then really kind of matured by Doug Evans when he was at MD Anderson. It was about which patients are at risk for having a margin positive resection. We knew that when patients get surgery up front, a positive margin was always associated with worse outcomes. And initially, they used some variable terms like impingement, abutment. And so those are always very hard to define because of the vague nature of the definitions. Matt Katz attempted to define it based on performance status as well as anatomic definition. And then Matt and I actually conducted a clinical study, the Alliance 0211. And as part of that clinical trial, we defined it based on geometry, which was 180 degrees. So a borderline resectable tumor is any tumor involving venous structure more than 180 degrees, arterial structure less than 180 degrees. The only exception was hepatic artery, which could be more than 180 degrees. And the reason we came up with that definition was really based on some retrospective studies out of Japan demonstrating the risk of margin positivity based on geometric classification preoperatively. And the reason the hepatic artery is separate than the SMA or celiac is someone had mentioned it earlier, was the neuroplexus. So the reason arterial involvement is more significant than venous involvement is the artery is enveloped in a neuroplexus, the vein is not. So once a tumor invades the neuroplexus, then the tumor starts spreading longitudinally along the nerve sheaths, and getting a negative margin becomes much more difficult. So once you're past 180 on the artery, getting a negative margin on the artery becomes almost impossible. In the hepatic artery, on the other hand, there's not a robust neural plexus around the hepatic artery. So even if it's more than 180 degrees, you can still get a negative margin. So this tumor, to answer your question after a long-winded answer, is I would classify it as a borderline resectable tumor.
Okay, Basil, what do you think? Sorry, Basil, what do you think about this tumor based on the imaging and the presentation?
Yes, I mean, I would agree with what has been said. It's abutting the vein. It's probably not invading the vein, as Dr. Ali mentioned. Often with the histology, it turns out to be that the vein is not involved if you resect it. And often, as Dr. Ali mentioned, you can actually peel the vein off the tumor. But the problem is with R0 or R1 resection. You really want to avoid R1 resection at all costs, because of the poor prognosis it brings. So in this scenario, I would prefer to go for a histological diagnosis with a US fine needle biopsy, and then offer neoadjuvant chemotherapy or chemoradiotherapy before going to surgery.
We'll come to the management in the next. Ali, can you proceed, please?
I get to have a comment on this because I disagree with the classification. I agree with Dr. Sayed. We are in an evolving process about the definition of resectability, and the terminology was just changing with things. Maybe at the real life, we don't know even how to accommodate this or this. So I think it's not only how much from the vein is involved, or you need to resect the vein, because our mortality and morbidity from venous resection went down very nicely to less than 3%. So resecting a vein is not a big deal now in expert center with high volume. So the question, where is the tumor location? How common is this tumor will be very close to the vessels? Like in uncinate process tumor, it's very common that the tumor will be very close to the vessels, and without being locally advanced. Like if this is very ampullary tumor, it's going to be very huge to reach the point that will involve the veins. That's why we'll make it more dilemma to get to surgery. So many centers now in US, in Europe, they will consider partial involvement of the vein with, if you think that this will be easily resectable and reconstructable. And here I think the most important thing, what is the criteria of resectability and reconstructability? This will be different from surgeon to surgeon according to expert and again to the volumes. So for me, such a tumor, I can consider it right now resectable. It's not borderline resectable because the involvement of the vein is not big. I know it's a challenging surgery, especially when you go down toward the SMV and the branches. It will make it more difficult for the surgeon, but still, we can go for resection. It's not something that will add a lot of morbidity on the patient in expert hand. So for me, I will consider this as still resectable. If the involvement is more than 180 degrees, the arteries look really narrowed, or there is a thrombus, or whatever, any kind of this criteria, or there is both a suspicion of arterial and venous involvement, this is for sure borderline. But for those patients, I think we still have a room to consider it resectable, and we can go for surgery. And most of the time, we can separate the vein from the tumor. But again, if you have a suspicion to get, as Amouri said, R1 resection, or to get through the vein, then you have bleeding, you're gonna get a problem. So the approach for this, which we're gonna talk about later, it's totally different to go for artery first, and then we're gonna talk about this later. So this is my point.
Go ahead.
You allow me, Osama, for a small comment?
Yeah, please.
In this case, I always like to think of the borderline resectable disease as not a discrete stage of the disease. It's actually an evolving stage of an early resectable disease, progressively, increasing in size and affecting, locally, regionally, expanding until it reaches a locally advanced and then metastatic disease. So we have a borderline resectable disease in its early stage, and then it becomes somehow borderline unresectable, and then it reaches the locally advanced stage. And I think in this case, with the size and with the CA19-9, I would consider this patient as a high risk, even if Dr. Ali disagrees that this is a borderline resectable. I think this case, even if you call it resectable, it's a high risk. And I think this patient shouldn't be denied the neoadjuvant treatment, and every attempt should be done to get a tissue diagnosis beforehand to initiate neoadjuvant chemotherapy, because it's not a matter of resectability. Even if we call it resectable, it's a matter of what are the odds of having a negative margin resection, which is the only potential window for survival with the other sequence of therapeutic options that we have in hand.
Dr. Ahmed.
This is exactly what I said. Whenever you need to, so this is your call to decide whether you can go for resection with the good probability of R0 resection, and how difficult is the reconstruction, or how morbid this on the patient. Because, you know, if you get in a morbidity and the patient will have delay on the chemotherapy, this will be also taking the probability.
May I have?
Go ahead, Rola.
Yeah. I agree with the considering it potentially resectable or borderline resectable, we have to have a low threshold for neoadjuvant treatment. We know that pancreatic adenocarcinoma is a systemic disease, even if it is localized. So there is a potential of having micrometastasis. So giving chemotherapy upfront will help the tumor show itself. So if it is progressed, it will be metastatic, or if we can control it to achieve R0 resection, it's better. So if we are planning to go for surgery, no need for biopsy, but if we need to go for neoadjuvant treatment, we need a biopsy. So this is
Osama, can I add another point here?
Yes, please.
So the other issue here is not just the vein. The other issue is the size of the tumor, the location of the tumor, uncinate process, large tumor, 3 centimeter, I think if I recall, or larger. There is a good chance that the posterior margin will be positive. So it's not just the vein margin, it's the posterior margin also. And you end up with an R1 resection with the vein margin clear, but posterior margin positive. So really, you want to do the best you can to reduce the chance of an R1 resection. And I think, to my mind, I think the best way forward in this scenario would be to go for some form of neoadjuvant therapy in the first instance.
Okay, Ali, for the sake of time, can you proceed, please?
So this is, I'm sure we answered most of it.
Let's just do the poll here and ask our residents and fellows with us, what do you think should be done? Upfront surgery? Go ahead, Ali.
Upfront surgery, neoadjuvant chemo, FOLFIRINOX, neoadjuvant chemo, FOLFIRINOX followed by cap-based chemo radio, or neoadjuvant infusion 5FU and PPRT, or the panelists, if they have another regimen, they can discuss it also.
So the poll is open, and you can go for surgery, chemo followed by chemo radio, or chemo radio only. Can you please answer? We have 109 attendees and would love to hear from all of you if possible. Surgeons, oncologists, residents, students, would love to hear from all of you. Okay, for the sake of time, we have around 70% answers, and we're going to end the poll. So people had basically went 20% upfront surgery, 52% neoadjuvant chemo, and C is 26%. So Dr. Ahmed, is there something called the best neoadjuvant regimen for such case if we are going to do neoadjuvant, and what it is?
Yeah, so that's a great question. So, you know, based on studies in the both advanced setting, you know, we know that the active chemotherapy regimens of FOLFIRINOX in a combination of gemcitabine and albumin-bound paclitaxel. And then the adjuvant setting, the PREDIGE study demonstrated, you know, really significant overall survival with FOLFIRINOX, and the APAC study, APACT, was negative, which was gemabraxane in the adjuvant setting. However, you have to look at that data with a grain of salt, because there are highly selected patients who are put in the PREDIGE study. Patients were selected after surgery based on performance status and CA 99 less than 180. And more recently, we completed in this country the SWOG 1505 study, which was for resectable tumors, looking at combination of FOLFIRINOX versus gemabraxane in a perioperative fashion, 3 cycles before and 3 cycles after surgery. And in that study, SWOG 1305, there was no difference between FOLFIRINOX and no difference between Gem-Abraxane. In fact, the Gem-Abraxane arm had better pathologic response rate on the surgical specimens. So here at Cincinnati, we typically would utilize in very high functioning patients FOLFIRINOX in the neoadjuvant setting. In patients who we do not think is high functioning or we're concerned about the toxicity of FOLFIRINOX, we would be very, very comfortable using Gem-Abraxane based on the 1505 study. So I think FOLFIRINOX is a good option. I think Gem-Abraxane should not be forgotten. In fact, if you look at the APAC study in the FOLFIRINOX and you look at the primary endpoint was his disease-free survival, they weren't very different between the treatment arms in the APAC and the treatment arm in the FOLFIRINOX study. And in fact, I think the significance of the PERDIS study was really based on the very low survival rate seen with single-arm gemcitabine in that study. So, I think the data needs to be interpreted with some caution. But I do think FOLFIRINOX and Gem-Abraxane are both equally effective in a perioperative fashion.
How about the chemoradio rule in this kind of setting, Dr. Ahmed?
So you're really opening up a can of worms there. That's the holy grail of pancreas surgery is the role of radiation. I know based on the SPAC studies, the radiation has been eliminated from the treatment algorithm in Europe. In North America, it's institution. We just presented the data from the Alliance 0215, which was for borderline resectable patients, randomized patients to FOLFIRINOX, followed by surgery, followed by chemo, versus FOLFIRINOX plus SBRT radiation, followed by surgery. And in that study, the SBRT arm was closed prematurely based on interim analysis. And it was really, in my mind, poorly designed study that led to the closure of that arm. But what we can say is that radiation didn't improve survival. So there is no level 1 evidence that I know of that says radiation is absolutely necessary. Although we know, many will argue that radiation will decrease local recurrence rates, treat margins, be associated with higher pathologic response. But I think that Rula said it earlier, pancreas cancer is a systemic disease. It needs to be treated with systemic therapy. And so I think chemo is the most important.
Rula, how do you approach such settings when you want to give neoadjuvant in pancreas? What setting criteria you use other than the surgeon tell you this is maybe you need an upfront treatment? How do you think about it yourself?
Yeah, this depends also on the patient himself, the performance status of the patient, how the patient can tolerate the treatment. It's also important about if the patient is symptomatic or not. The higher CA 19-9, if the patient has a good performance status but symptomatic with high CA 19-9, we have to give FOLFIRINOX, considering the patient will tolerate the treatment. And it will be modified FOLFIRINOX, that the dose of irinotecan will be the 150 milligram per meter square rather than 180, and without the bolus 5-FU.
Okay.
And this, yeah.
Okay, one question, Rula. Do you guys do, I left KFCC myself, but do you guys do any genetic profiling on any specific?
Yeah, I know.
The biopsy,
Yes.
the type of treatment, if you want to give.
Yes, we are now running a study for genetic profiling of every patient with pancreatic cancer in order to look for BRCA mutations that we know it is like in 10% of the cases. And there is data about tailoring the treatment according to the presence or absence of germline or somatic mutations in those patients. We know that FOLFIRINOX is indicated if we have the genetic mutations. And if not, we can go for, there is data for Gem-Abraxane, or if the patient does not have a good performance status, we can start with FOLFOX, then add irinotecan later on. So now every single patient is referred to the genetic clinic for counseling, and genetic testing is being done for them.
So Dr. Ahmed, what do you think about the gem-cisplatin in patients with BRCA1 mutation? What's your experience with these patients in terms of response to
Right.
treatment?
So, we have to be a little bit careful about understanding, again, the literature. So the genomic testing really is relevant for advanced pancreas cancer. So, that's based on the POLO study where giving patients olaparib, which is a PARP inhibitor, along with platinum therapy, benefited patients in progression-free survival, not overall survival. And then there was an update presented at recently at ASCO, which again did not show benefit in overall survival. I do think, though, having said that, that there is a role for collecting data, doing genetic analysis, but right now in the adjuvant setting, there's no role for any biologic agents. There's no role for PARP inhibitors, the platinum therapy. It's all for advanced cancer. Now, one study that we are currently doing here is looking at transcriptomic classification of pancreas cancer. So patients are biopsied, and we try to understand whether they're classical or basal transcriptomic signatures. There is data coming from Zhenzhen Ye's lab at, in this country, University of North Carolina, where classical subtypes of pancreas cancer are much more responsive to platinum-based therapy, oxaliplatinum therapy, and basal is much more sensitive to gemcitabine-based therapy. So we're doing a clinical study right now where we do a needle biopsy, do transcriptomic classification, and then decide the chemo based on that. Again, this is just information gathering. There's no level 1 evidence to suggest that that's standard of care at all. But I think there's no for resectable tumors, there's no actionable mutations in pancreas cancer that will change our treatment modality.
Yes. I agree with Dr. Ahmed also that our data for neoadjuvant or adjuvant are extrapolated from the metastatic. So FOLFIRINOX have moved from metastatic to adjuvant now to neoadjuvant. So we may have more data to also involve PARP inhibitors or cisplatin based later on as we go with more evidence.
For the sake of time, Ali, can you proceed, please?
And yes, I have a question for Rola mainly and for the other panelists. We know that the average age of pancreatic cancer get almost late 60s, 70s. So most of the patients, they are performance status not that much perfect. They're going to be emaciated, weight loss. Our argument for giving a new adjuvant that about only 60% of patients, they can get adjuvant treatment post-surgery because of the stress of surgery, sometimes certain complication. So giving a new adjuvant for borderline, as we agreed, this will help in clearing the margin, improving the R0 resection, all these things. How tolerant your patient, Rola, for such a harsh regimen, FOLFIRINOX now? Yeah, and in my practice, I see many patients, they even could not finish the full course of a new adjuvant. And for Dr. Sayed, how many patients they will drop off the new adjuvant and then the medical oncologist will call you, this patient cannot continue and he need to go for surgery. And then do we have patients that will get a new adjuvant, then we cannot do surgery for them because of the morbidity and complication of chemotherapy also?
Yeah,
we need to take this in consideration.
So again, there is data to answer this question. And so if you look at our results from the SWOG 1505 study, to answer your first question, how many will finish neoadjuvant therapy? The answer is greater than 90% were able to finish neoadjuvant therapy. 10% did not go on to surgery because of either progression of disease or toxicity of chemotherapy. So your question is very, very important. These regimens can, in a subset of patients, lead to deterioration of performance status where they can't go to surgery, but that number is less than 10%. To answer your third question is how many will not be able to go on to adjuvant therapy? And again, from the SWOG 1505 study, the answer is roughly about 50%. So 50% of people who completed surgery were able to finish adjuvant therapy, 50% were not. And so based on that, if you believe that systemic therapy is the most important part of the trimodality therapy, the push now is to give total neoadjuvant therapy, to give all of it up front because patients can't get it post-op. And there's a study again in this country, Alliance 0218, led by Christina Ferroni at Mass General, that is open looking at total neoadjuvant therapy versus adjuvant therapy for pancreas cancer. So your questions are very relevant and very important. Most can finish neoadjuvant. There is a subset that have deterioration because of the toxicity of multi-agent therapy, and only about half can finish adjuvant therapy. And based on that, there's a push to make everything total neoadjuvant.
So this is a result from the US patients. Let's ask Rula, Zahrani, Amouri, from your experience, do you have, I know you don't have maybe study to give me a real number, but do you think our patient getting FOLFIRINOX neoadjuvant, 90% of them can continue the full course and they can tolerate it and they will be able to go for surgery?
Ali, as I said, it will depend upon the performance status of the patient. And unfortunately, we have a good percentage of young patients. So we have to push hard with them. So if they have poor performance status or older, we can go with FOLFOX, then we add irinotecan later on. Or if they cannot tolerate chemotherapy, I don't think they will tolerate Whipple surgery.
Dr. Zahrani, Dr. Basil, can you comment?
Yes, I just wanted to raise the question actually about preoperative and so neoadjuvant chemoradiotherapy. We know this new Dutch trial has been published last year, the pre-op Panc trial, showing no significant difference in overall survival for those who had neoadjuvant chemoradiation versus who had surgery up front. But they showed some significant differences in terms of R0 resection, pathological response, and so on. I must say, I haven't had a great experience with neoadjuvant chemoradiotherapy followed by surgery. I've had the occasional patient who received radiotherapy and had surgery. And although they are saying that in their trial that the morbidity, the operative morbidity is not different in the two groups, I am a little bit concerned about that. Did Dr. Saeed, for example, had an experience with the neoadjuvant chemoradiotherapy followed by surgery? What is the surgery like in these patients?
Yeah, that's a good question. So the first to address the PREOPANC study, this was the multi-center Dutch study, which is very, very hard to interpret. First of all, it's a study that included both resectable and borderline resectable patients. The definition of borderline, though, was less than 90-degree involvement, so it's not the traditional definition of borderline. The primary endpoint was overall survival, and it was not significant, 16 months versus 14 months. But there was a difference in disease-free survival for patients getting neoadjuvant radiation. But remember, that's a subset analysis. It wasn't powered to look at disease-free survival. It was powered to look at overall survival. So most consider this a negative study. There are other studies being done in Europe looking at radiation pre-op, including the PREOPANC 2 study and follow-up on the PRODIGE. So those studies are ongoing. So we'll have more studies looking at the radiation question. In terms of morbidity, I think that there is no greater morbidity if patients have gotten neoadjuvant therapy. And one can even argue that if a patient gets neoadjuvant radiation, the morbidity is less, because what happens is the radiation causes hardening of the pancreas. So the fistula rate is much less. So typically after a Whipple operation, the pancreatic fistula rate is anywhere from 15 to 25%. In Sam's hands, it's probably like 2%. But after you give radiation, the pancreas becomes harder and the sutures hold better. So the fistula rates really drop to single digits. So the dissection is not more difficult. The outcomes post-op morbidity is not more. And perhaps if they got pre-op radiation, post-op fistula rates are less.
Muhammad?
Allow me, Osama, for a comment.
Yes, please.
I think I would agree with the group. Since we are trying to build our practice based on the best available evidence, and there is no reason to separate our justification for giving neoadjuvant treatment because of lack of local data that are enough to be presented. In our center, actually, there is more consensus towards neoadjuvant chemotherapy. More patients are getting neoadjuvant chemotherapy before surgery, and I think that's that should be the way. I believe neoadjuvant chemotherapy is the way to go, and I think more evidence is going to collect down the road to build a level 1 evidence to make it a standard of care, given the fact that surgery alone is not the answer to treat pancreatic cancer, being a metastatic or a systemic disease in the beginning. And doing surgery, omitting neoadjuvant chemotherapy will give patients only 50% chance of being able to get the chemotherapy, like Prof. Ahmad has mentioned, and Dr. Arola. The last patient I've done was a week ago, neoadjuvant chemotherapy completed. We did his surgery, ERAS protocol, enhanced recovery after surgery protocol. We abandoned the use of drain, and this patient was not an exemption, and he was discharged a week later, 6 days later. So I think, I strongly believe that neoadjuvant chemotherapy is the way to go.
I think not for resectable. I think for borderline resectable, there's some argument to test the biology. I have tried it with a lot of borderline resectable pancreas, and we made them to resectable. But let's just make sure the evidence for resectable based on the SWOG trial is not enough to say it is for resectable. Is that right, Dr. Ahmed?
Yeah. So the SWOG study was for resectable, and it wasn't comparing the regimens head to head. It was a pick the winner design. But again, you know, if we really get down to the nuts and bolts about neoadjuvant therapy, you know, if you compare, my belief is that if you do an intent to treat analysis of pre-op versus post-op, it's probably not going to be different. There's two big benefits to neoadjuvant therapy, and they're hard to capture in a trial. Benefit number one is what you said, testing biology. We know that pancreas cancer is a systemic disease, that majority of patients have occult metastatic disease at presentation. The process of developing metastasis probably takes about 3 years. So they probably have already developed metastasis before they became symptomatic, before they were detected. And we know that if you operate on someone right off the bat, surgery first, about 30% of people will reoccur within 3 to 6 months of surgery. Those are 30% of people who underwent unnecessary surgery and were delayed in receiving the therapy that will make them live longer, which is chemotherapy. By giving neoadjuvant therapy, you're able to figure out who those 30% of people are, because they're going to progress on therapy and never get unnecessary surgery. So one benefit of surgery is to select out the patients who have systemic disease that you can prove, and not to do unnecessary surgery on them. The second is what we've talked about, which is giving them adjuvant therapy. We know that if you do surgery first, again, about 30% to 50% of people will not get adjuvant therapy. And if you truly believe pancreas cancer is a systemic disease, then why wouldn't you use a treatment sequencing that maximizes the number of people who get the most important aspect of the therapy, which is chemo? And neoadjuvant therapy allows you to do that. So, you know, I think the two benefits of neoadjuvant is making sure people get adjuvant therapy and only operating on people who are likely to benefit.
Okay. Ali, can you proceed?
Okay.
We don't have enough time.
Actually, we went for upfront surgery for such lady. Okay, this is the image intra-op. Here is the, let me stop this. We are looking from the left side of the patient. This is the liver here, and down is the feet. So this is our resident. This is the portal vein here, the splenic artery. This is the SMV, just joining the junction of the SM. So this is the IMV, sorry, joining the SMV and portal vein. And this is the area where we have the problem. The tumor is attached to the mainly the right side of the SMV toward the ileal branch. So the black area here, I just tried to delineate where we have the encasement of the sphenomesenteric vein from the right side. So before going to such resection, you need to think really for a long time, because this is the clamp, this is a bulldog on the ileal branch, just to make sure the bowel will not really get badly affected, because you don't know how much collateral is going to be there. This is the middle collectite here, the right collectite, the right gastroploic. So the whole bowel drainage will be depending on the ileal branch from the small bowel point of view, and to the IMV from the colon point of view. So if you have a trouble here with your anastomosis, the risk of venous ischemia will be there. So we just put, I don't know if Dr. Sayed or Zahrani Amouri, if they have comment on this. If you have encountered such scenario, what do you think the best way to deal with this resection? I usually try to test before to go for major resection, because the implication or the sequelae of that on the bowel will be very tough. So what I did is just clamp this for a while, make sure the bowel will be fine, and then we did the resection of this piece, and then we joined the jejunal branch, the main jejunal branch of the, for sure the first jejunal is gone because it's the other side. So the main jejunal with the SMV.
So I had a hard time following what you said. So the tumor was involving the ileal branch, but the main SMV was fine?
This is the main SMV. Part
And
of it is involved
was the main
from the
SMV
right side,
involved with
180
tumor?
degree.
90 degrees?
Yes, it is the right side of the SMV with the ileal branch, which is here.
Yeah.
Is in, yeah, this is the area where the tumor affecting the vein.
Yeah, yeah.
Here.
So, I mean, I think what you did is perfectly fine. So, you know, one of the things I always teach my residents is you have to be, if you're going to do pancreas surgery, you have to be a master at venous anatomy. Before you walk in the operating room, you should know the anatomy in your sleep. You should know where the IMV drains, whether it goes into the SMV, pleural splenic vein confluence, or whether it goes into the splenic vein, and where is the coronary branch? Where's the left gastric drain? Does it go into the splenic? Does it go into the pleural vein, as it does in 80% of the time? A patient like this, I would have done an artery first approach, where I would have cleared the artery first, and exactly, and then I would have gotten control of the as you've described where you are. For uncinate, usually it involves the SMV below the splenic vein entry point, and you can usually just resect and either reattach like you did, or do an interposition with either the left renal vein or the left IJ vein. We typically try to use the left renal vein because the size matches well. Sometimes we'll use the left IJ. And if the tumor involves the vein at the confluence of the splenic vein, we'll take the splenic vein off, reconstruct. And if the IMV goes into the splenic vein, we won't reimplant the splenic vein. If the IMV does not go into the splenic vein, then we'll reimplant the splenic vein, as long as the coronary is in the pleural vein. So I think what you did is very good. Artery first to clear the artery, and then tackle the vein.
Great.
So just for the resident,
because of the sake of time, it's almost an hour over. Can you show us the pathology, and then we'll finish, please?
So just this is the we did the primary anastomosis, Prof. We did not need to use interposition graft. I think with Kettle-Brach and raising the root of mesentery, you can have a room to do it without, unless if the segment of the vein resected is a really big one, so you need to interposition. For this case, I could do it without interposition graft. Sorry. So basically, we did a pilus preserving Whipple with superior mesenteric vein resection reconstruction. This is the specimen here. This is the piece of vein. It's around like 3 centimeters. So this is the pathology. It's tumor size 4.7 by 4.3. The superior mesenteric vein length resected was 3 centimeters. It's moderately differentiated adenocarcinoma. All the margin were free. There was a perineural invasion. It is a T3N1, one out of, there is 13 lymph node here and another 4 lymph nodes. So it's almost 1 out of 17 lymph node was positive, invading the wall of the sphenomesenteric vein and narrowing the lumen. Our next question, because we did not get to neoadjuvant in such case, what do you think the best available adjuvant treatment for such a lady?
Okay, so gem alone, capecitabine, fulfernox, chemoradiation observation. Can you guys answer, please? And we'll have maybe Rula, can you comment on this, please?
Okay, we know that gemcitabine was the standard of care before. Then came different regimens that proved better efficacy, like capecitabine later on, then the FOLFIRINOX, but there is no head-to-head comparison between capecitabine and FOLFIRINOX, but with the survival data, progression-free and overall survival data with the FOLFIRINOX, now modified FOLFIRINOX is the standard of care as the adjuvant treatment in patients with adenocarcinoma for 6 months, which is 12 cycles of treatment.
Okay, so that's what the majority of our attendees had. Okay, so I'm gonna just go ahead with some questions from the attendees. Dr. Ahmed, what do you think the utility of using PET scan in such case without a definitive histopathology diagnosis preoperatively to confirm malignancy? This is from Dr. Mais Halase. She is our nuclear physician that's worked with us.
I think it needs to be used in conjunction with all modalities. I'm not aware of any literature that suggests that PET scan can be used in lieu of tissue diagnosis to confirm, cancer. Oftentimes patients with cancer can have some peritumoral inflammation, and I wonder whether you can get some false negatives, but I think it needs to be used in conjunction with other modalities, not separately.
Okay. Another questions from Dr. Muhammad Eid. SBAC 5F trial, borderline resectable pancreatic cancer. It says the resection rate was 60% for upfront surgery versus 55% for neoadjuvant therapy. Can you comment on this?
This trial is a phase 2 trial. It has a 4-arm study comparing different modalities of neoadjuvant, but the rate of R0 resection was more with the neoadjuvant chemo or chemoradio, and R1 resection was more with the upfront surgery. Also, patients who received different modalities of neoadjuvant, there were no difference between them. Maybe toxicity was more with FOLFIRINOX, but the 12-year survival was more with FOLFIRINOX. And there were only interim data in the last ASCO.
Okay, great. Well, I would like to thank you all for being with us for this 1 hour. We're gonna promise everybody to make it 1 hour. So basically people would not leave the time. Dr. Ahmed, thank you very much for being with us in your busy clinic. Ali, thank you very much. Dr. Zahrani, Dr. Amouri, Ihab, and Rula, thank you very much for this wonderful night, and would love to have you guys again in the near future. Thank you very much.
Thank you very much.
Thank you, everyone.
Thank you, guys. Thank you.
Nice job, everybody.
Nice to meet you all.
Nice job. Excellent.